Schizophrenia. Just a little bit of a warning, I do refer to schizophrenia with SZ on the PowerPoint. It does mean schizophrenia. Symptoms and features of schizophrenia. Features. Males have a higher proportion of negative symptoms and a longer duration of the disorder than females. This shows a gender difference. The onset of the disorder is between adolescence and mid-30s. The likelihood of individuals developing schizophrenia is between 0.3 and 0.7%. It affects 1% of the population and is more common in lower economic groups. The peak of schizophrenia is mid-20s for males and late 20s for females. 10% die of suicide. 15% of schizophrenic people remain chronically ill, requiring regular treatment and intervention. Cognitive functioning defects can take place, impacting working memory, language, functioning, and speed of information processing. Mood abnormalities are common, and 25% completely recover. Symptoms. For diagnosis of schizophrenia, you need to have 2 or more symptoms and a high proportion of symptoms in a month. There are 2 types of symptoms, positive and negative. Positive symptoms are something that add to the experience. For example, disorganized speech, inappropriate speech, dog, piss, red. This doesn't make any sense. Disorganized behavior. This severely disrupts the ability to perform daily tasks. Disorganized thinking. You find it hard to think in an ordered and logical way. Excessive motor activity. Moving in an odd and disturbing ways that is purposeless and not influenced by an external stimuli. Encoder, repetitive encoding of words spoken by others or imitation of mannerisms of people. Thought insertion. Some people think their thoughts are put there by someone else. Finally, you have to know about hallucinations and delusions. Hallucinations are things that are not present. You have 2 types. Auditory hallucinations, which is hearing something that isn't actually there, and visual hallucinations, which is seeing something that isn't actually there. Delusions is a false belief. For example, persecution, believing that people are plotting against them, being spied on, or that they're being talked about behind their back. As well as this, individuals can have delusions of grandeur where they believe that they're someone grand or famous. Negative symptoms is something that subtracts from normal behavior. For example, social withdrawal, alleviation, a lack of motivation, catatonia supurna, which is standing emotions, inappropriate effect, which is silliness, and laughter, which is out of context, apathy, a loss of interest in normal goals, flat emotions, which is having no emotional response, grossly disorganized behavior, difficulty in goal-organized behaviors, and loss of drive, feeling drained of energy and unable to initiate or complete a course of action. The neurotransmitter explanation of schizophrenia. So it's good to have some background on what neurotransmitters are and how synaptic transmission works, and I do have a video on this. However, here is how synaptic transmission works. An axon potential gets sent through an axon hillock towards the terminal button where vesicles are located and filled with neurotransmitters. Once the message reaches the axon, calcium channels open and release calcium ions. Calcium ions trigger the release of vesicles. The vesicles will fuse with the outer membrane of the terminal button, releasing neurotransmitters into synaptic cleft. The receptors on the postsynaptic neurons will absorb the appropriate neurotransmitters through the lock and key method. Any neurotransmitters that are not absorbed by the postsynaptic cleft will be destroyed by enzymes in the synaptic cleft or be absorbed by the presynaptic neuron via reuptake. Reabsorbed molecules will be destroyed by enzymes to turn off neurons in preparation for future action potentials. Once the message reaches the axon calcium channels and opens and releases calcium ions. Dopamine. Dopamine is known as the feel-good hormone. It's in charge of making you feel happy, satisfied, and motivated. Patients who abuse amphetamines, if you don't know what amphetamines are, they're a type of drugs that increases dopamine. This can lead to positive symptoms of schizophrenia when they abuse amphetamines. Randeur and Mulcahy, 1966, injected rats with amphetamines, and this led to aggression and isolation, and it also led to psychotic symptoms. Hyper and hypodopaminergic. Hyperdopaminergic. Hyperdopaminergic is when schizophrenia is linked to high levels of dopamine. It's unclear what causes this. It could be that an individual has an excess of D2 receptors on their postsynaptic cells, or they have a low level of hydroxylase, which breaks down dopamine, and if they have a low level of this, it can lead to a build-up of dopamine. However, there's also a theory of hypodopaminergic. Kenneth and Davis et al. 1991 suggested that positive symptoms of schizophrenia, delusions and hallucinations were due to an excess of dopaminergic activity in the mesolimbic pathway, whereas negative symptoms, low mood, were a result of hypodopaminic, a lack of dopamine in the mesocortical pathway. This suggests that both hyper and hypodopamine work together to lead to schizophrenia. D2 receptor hypersensitivity hypothesis. D2 hypersensitivity theory is the thought that D2 receptors are more likely to overreact in the presence of dopamine. There's different ways that brain receptors react to dopamine. Lieberman et al. 1987. 78% of schizophrenic patients are more likely to take amphetamines and show new symptoms / increased psychosis. However, only a small proportion of those who regularly use suffer these symptoms. Seaman 2003. Schizophrenics, a higher number of D2 receptors, a higher affinity to dopamine. More dopamine is absorbed by the postsynaptic cleft. Owen et al. 1978. Post-mortems of schizophrenic patients show higher D2 receptors. You could say that this theory has temporal validity, as is research done in 1978 and 2003 that backs up this account. Glutamate and dopamine dysregulation. Glutamate controls the amount of dopamine released by the brain and lowers the levels of dopamine. A reduction in glutamate can therefore increase the amount of dopamine released. Carlson, your contemporary study, supports that a lack of glutamate actually leads to schizophrenia. Dopamine dysregulation. This theory suggests that more attention should be paid to high presynaptic dopamine levels, interactions between genetics and environment, and socio-cultural factors. Oliver Howes and Shigiri Kapoof 2009 said that dopamine dysfunction in the striatum leads to psychosis. There are two neurotransmitters explanations that do not include dopamine. This is the GABBA explanation and the serotonin explanation. GABBA is a neurotransmitter that produces a calming effect. It helps regulate anxiety and mood control and sleep. A reduction in GABBA can lead to anxiety, mood disorders, and seizures. Serotonin. It regulates sleep, helps mood, appetite, and digestion. An increase in serotonin can lead to positive and negative symptoms. It's important to highlight how the serotonin explanation can explain both positive and negative symptoms, as the dopamine explanation cannot. If you're going off the D2 receptor or hyperdopamine explanation, then it can only explain positive symptoms, not negative symptoms. However, serotonin can. Traditional antipsychotic drugs which block dopamine work. Atypical neuroleptic drugs which block dopamine and serotonin have been effective and have fewer side effects and can increase dopamine. Parkinson's is associated with low levels of dopamine. People are prescribed L-dopamine, a dopamine antagonist. However, they can suffer positive symptoms due to the dose being too high. Schizophrenia often coincides with depression and substance misuse. About 50% of schizophrenic patients are at risk of misuse. This is accounted for by the changes in concentration of dopamine in different areas across the brain. This revised hypothesis suggests that neurotransmitters can explain both negative symptoms, depression, which others can't. A reduction in the mesocortical pathway leads to the flattened effect. So that's the explanation of the hypo and hypodopamine explanation. Dopamine antagonists can cause uptake regulation. This is where the brain produces more of something in response to its decrease. It's reductionist. It explains a complex disorder but ignores biological and psychological and social factors. Bailey and Brown, 1968. 50% of patients that suffer from schizophrenia suffered a traumatic life event 3 weeks before relapse, suggesting social conditions impact the onset of schizophrenia. Ethics. Individuals with schizophrenia cannot provide informed consent to treatment. They may not understand the implications. However, Antipsychotic drugs can lead to a better quality of life. Alper and Fredoff, 1980. Patients showed no improvement from taking dopamine antagonists, which prevent dopamine from being absorbed. Brain scans can only be taken once schizophrenia is confirmed, so it's difficult to prove cause and effect, whether dopamine sensitivity leads to schizophrenia or whether schizophrenia leads to brain change. Genetic explanation of schizophrenia. So the human genome has 23,000 sets of genes. Each have specific instructions that build up our unique being. Schizophrenia runs in families, and the more closely related you are, the higher risk you are of having schizophrenia. Genetic makeup is from both parents, about 50%, one from each parent. Therefore, if one parent suffers from schizophrenia, you have a 50% chance of that gene being passed on. There's a 48 concordant rate with identical twins, MZ, and if both parents are carriers of the schizophrenia gene, there's a 25% risk to you. There's a 6 to 17% risk if you have a first-degree relative who has schizophrenia. There's a 2 to 6% risk if you have a second-degree relative with schizophrenia. And there's a 1% risk to the general population of having schizophrenia. Genes involved with schizophrenia and the stress diathesis model. Genes involved. The DISC1 gene. This gene is involved in brain development and synaptic functioning, and mutations are associated with increased risk of schizophrenia. The NGR1 gene. This gene affects brain communication, and variants lead to schizophrenia. The COMT gene. This affects dopamine regulation in the brain, and if you've watched the neurotransmitter video, or if you're watching the long video, then you know too little dopamine can lead to negative symptoms, and too much dopamine can lead to positive symptoms of schizophrenia. The stress diathesis models. The genetic risk may be triggered by environmental factors, for example stress. Genes create a vulnerability and the environment can activate it. Not everyone has risk genes to develop schizophrenia. Adoption and twin studies. If you don't know what these are, I suggest you watch my video on it, especially since I go over Gottman and Shield and Getz in it. Adoption. This is when you compare biological and adoptive parents to their children. There's a 1 to 10% risk. Disorder is down to genetics. It can be expected that biological parents will share the disorder with their children they will not have raised. It's shown a concordance for schizophrenia is 4 times as high in MZ twins compared to DZ twins. Twins. Compare the variance between MZ twins 100% and DZ twins 50%. Argue that as one twin has this disorder, the other will suffer. If you are confused, please go watch the video on adoption and twin studies as I go over this in a lot more detail. Strengths. Genetic counselling, if diagnosed with schizophrenia, means that risk can be calculated and counselling can be put in place to aid the family. Harrison and Owens, 2003, found that risk was about 10% higher in close family members of schizophrenia. Harrison and Owens, 2003, found 6 different types of genes involved in the development of schizophrenia. Tark and Downhown, 2017, found that the DISC1 gene is associated with the presynaptic dopamine dysregulation explanation of schizophrenia. Michelle and Egan et al. Found a link between a decrease in dopamine activity in the prefrontal cortex and one form of COMT gene and 2 copies of it leading to schizophrenia. Gottman and Shields, 1991. I have elaborated further on this study in my twins and adoption video. However, Gottman and Shields showed that there was a concordance rate with genetics using twins. They found that MZ twins had a 48 concordance rate and DZ 17%. Although there's not a 100% concordance rate, meaning both nature and nurture must impact whether or not an individual develops schizophrenia. 7% of adoptees with schizophrenia had a biological mother with schizophrenia compared to 2% who had a biological mother without schizophrenia. Terriana et al. 2000 compared children adopted away from their biological mothers who had schizophrenia. However, they still had a higher rate of schizophrenia than the normal population. As well as this, the genetic explanation for schizophrenia reduces blame from the individual who's schizophrenic, who may feel like it's their fault for developing schizophrenia and their actions due to the schizophrenia. Weaknesses. Now, we talked about this with Gottman and Shield, but the concordance rate isn't 100%. Carson, Passman, and Passbean, Morstein, 2006, showed that cities led to schizophrenia. and rural areas did not lead to schizophrenia. This suggests that there's more than just a genetic explanation for schizophrenia, and this explanation should be used alongside social reasons. Research has failed to isolate a single gene, recessive or dominant, to explain schizophrenia. This is from Tamingers, 1991. Adoption and twin studies often have small samples and therefore cannot be generalized. As well as this, twins have an unnatural life and therefore cannot be applied to the general population. Reduces the likelihood that behavioural treatments can assist an individual with schizophrenia. Ezra Sosa and colleagues, 1992. Early perinatal nutrition can increase the risk of schizophrenia. It's deterministic to say that this is the only explanation of schizophrenia, and there's also other explanations, the dopamine hypothesis and the social causation hypothesis. The social causation hypothesis of schizophrenia. Environmental factors affect your chance of having schizophrenia. Since the 1950s, a higher rate of schizophrenia have been found in lower classes. Stress, malnutrition, cannabis use, and growing in urban areas also affect your chances of having schizophrenia. Also, factors that affect the development of schizophrenia is social isolation, which can lead to you having delusions, adversity in adult life, unemployment and poverty, which can lead to doing drugs, which can lead to an increased amount of dopamine in your system, separation from parents as a child, which can lead to you being in the social care system, inner housing and poverty and overcrowding. All these factors can lead to a change in brain plasticity during childhood, which can increase your likelihood of developing schizophrenia. Social class. Schizophrenia has been found in lower classes among unemployed and deprived areas. Social class can impact levels of stress causing schizophrenia. People tend to experience different causes for illnesses and different medical care in lower classes. The rate of schizophrenia in lower classes is 4 in 1,000 in white lower classes and black immigrant lower classes. Lower class of patients tend to be brought into medical care systems by police or social services to become compulsorily admitted, and they tend to become long-term cases. This can lead to a misdiagnosis or positive skew for individuals who regularly come into contact with authority, as they are long-term cases. Lower social groups tend to have a higher incidence of schizophrenia. This means social class may cause schizophrenia, and this was thought to be the cause of schizophrenia for a long time. Social adversity. Exposure to hardships as a result of social circumstances. Social class is a risk factor of schizophrenia. However, this theory is outdated, and therefore led to the social causation hypothesis being developed. Cooper 2005 found that single men in unskilled manual labor jobs were 4.1 times more likely to develop schizophrenia than men in managerial roles. White people in lower social groups do not show an increased risk of having mental disorders like black immigrants, due to them having more social standings. Cities lead to drug use, crowded areas, and no medical care. Eaton 2000. Living in cities rather than rural areas increases your chances of schizophrenia. The tendencies for schizophrenia comes from what's happening to someone during their childhood and early childhood. It's to do with the children's living conditions rather than social adversity. Hyam et al. 2004. Social adversity in childhood relates to the development of schizophrenia later in life. Pressure in childhood and adolescence is linked to being in a lower social class and schizophrenia. Immigrants. Immigrant populations are more likely to be at a disadvantage in educational, attainment, social class, and standards of housing, discrimination, and overcrowding. Schizophrenia is higher in people of Afro-Caribbean descendants. This is because they're more likely to experience unemployment, living in inner-city areas, and worse situations than other people of same ethnic backgrounds. Brown 2010 looked at Veiling 2008, where they carried out a study to see if immigrants resided in the areas where ethnic groups did not prominate, there was a higher rate of psychotic disorders compared to areas where it did. Social factors can affect the development of schizophrenia, and it can increase the risk. There is a higher incidence of schizophrenia in Afro-Caribbean and black immigrant populations. They are 4 times more likely than a normal individual would be. Social drift theory states that with severe mental health problems, people tend to drift down the social hierarchy into lower classes over time. Cooper 2005 found that the rate of schizophrenia in second-generation African-Caribbean people is higher than the first generation. This suggests environmental effects. The first generation of immigrants expect social adversary. However, the second generation doesn't. Therefore, when social adversary comes their way, they may tend to drift down the social hierarchy. Strengths. Eaton found through meta-analysis of 17 studies that the rates of schizophrenia is much higher in lower class areas than upper class areas. This supports the social causation hypothesis. It explains the nature and nurture approach. It considers the adversity people faces. It suggests that this adversity could trigger the onset of schizophrenia. This is holistic perspective. Studies show that there are many social factors. Morton showed that living in an urban area increased the risk. However, all studies look at different causes, so some studies show that living in a city increases the risk. As well as this, there's much research support, as we've talked about. Weaknesses. There may be issues with diagnosing schizophrenia rather than the environment. The RCD and DSM have different ways of diagnosing schizophrenia. This makes studies like Cooper et al. Very unreliable, as even though they use the DSM to diagnose, this only has a 60% same diagnosis rate. Cause and effect, whether it's social adversity that leads to schizophrenia or schizophrenia leads to social adversity. It doesn't account for individual differences. The other explanations, genetic and neurotransmitter. Social drift theory may be a better explanation. Social drift of the mental illness, leading to people going down the economic ladder. Social drift theory takes away the blame from the individual, as it's not their fault that they have become poor. However, it's deterministic and they have no free will with this theory. They're going to become poor because of their mental illness, no matter what. Drug therapy used to treat schizophrenia. Antipsychotics are a drug that are effective in reducing symptoms of schizophrenia. They block D2 receptor cells and depolarize the neuron to reduce the level of dopamine in areas of the brain associated with symptoms of schizophrenia. There are two types of antipsychotics, typical and atypical antipsychotics. Typical antipsychotics were developed in the 1950s, e.g. chlorpheniramines, which block the way your brain uses several neurotransmitters, especially dopamine, and this can be taken in tablet or injection form. Developed in the 1990s as typical antipsychotics were having some unpleasant side effects, atypical drugs block certain types of dopamine and serotonin receptors and activate certain other dopamine and serotonin receptors. Barr et al. 1997 found that clozapine was highly effective in reducing both positive and negative symptoms, e.g., emotional withdrawal. Seaman 2002 found that reducing serotonin reduces the unpleasant side effects of antipsychotic drugs, which is why atypical drugs seem to work better than typical drugs. Ethics. If necessary, schizophrenic patients can be detained under the Section 3 Mental Health Act 1983. Treatment can be given without consent if deemed necessary. No consent can lead to patient harm. However, some schizophrenic patients won't have the mental capacity to consent to the treatment. The lack of consent can be justified by it improving a schizophrenic's life. Atypical drugs have horrible side effects like drowsiness, blurred vision, and rapid heart rate. Typical drugs also have side effects like weight gain, metabolism changes, increased risk of diabetes and high cholesterol, and possibility of hydrodyskinesia. Now, if you don't know what this is involuntary muscle spasms, which are irreversible. Now, both of these drugs can be given to someone under the Section 3 Mental Health Act 1983 without their consent and can lead to all these side effects. This, therefore, leads to question whether or not we're doing this for the patient's best interest or whether we're doing it to control them. Social control. In 1930s, electric shocks were used to induce seizures and treat people with schizophrenia. In the 1960s, this was deemed barbaric and a form of social control to make the patient docile and easy to control. Some medication makes patients passive and therefore are known as chemical straitjackets. Guidelines suggest that electric shock therapy may be effective for those who do not respond well to drug therapy. However, it can be said that drugs and shock therapy are just another form of social control for a different way of thinking. Antipsychotic drugs are effective in reducing symptoms. Maltese et al. 2004 found that Hyperdopaminergic antipsychotic drugs work better than placebo. Harting et al. 2012 found that Hyperdopaminergic improves positive symptoms more than ozolpropane, but ozolpropane improves negative symptoms. However, findings are not firm. The dopamine hypothesis has a strong biological basis, and therefore this can be seen as a reliable treatment. Clozapine is highly effective, it has few side effects and less complaints, however it increases the risk of ankylosing, which reduces white blood cell counts, which can lead to a risk of an infection. Gutto et al. 2001 found few differences between antipsychotic drugs and found that side effects may affect the quality of life for schizophrenics drastically. Therefore, the application for schizophrenic drugs being accessible for everyone is not there. Patients do not always continue to take the drugs. Gusto et al. 2011 found that the discontinuation of drugs were between 37 and 47%. Lieberman 2005 found that patients stopped taking their meds due to serious consequences for effectiveness of treatments. Cognitive behavioural therapy, or CBT, for schizophrenia as a treatment. CBT is based on both cognitive elements as well as learning theories, and it addresses the thinking and behaviour involved in schizophrenia. It can be done in one-to-one sessions or in group therapy over a number of weeks. It can be done through self-help books, online, or family therapy, or structured activities. Patient-therapist relationship is important during CBT, and focusing on the therapist being non-threatening and supportive. CBT involves examining the things you think and do, focusing on goals and the present day and how your thoughts affect your feelings and behavior. Belief modification is challenging the delusional thinking directly and testing it against reality. Normalizing is destigmatizing the psychotic experiences using relaxation techniques and activity planning to normalize psychotic experiences so they don't feel as overwhelming. Motivational interviewing identifies a person's goals or values and seeks to help them to change and find out how they can change. Focus and retribution. This reduces the distress of hallucinations. It focuses on the characteristic of voices and patients' records of what they say. Skills training, learning to self-manage and how to find support, social skills and life skills are learned. Psychoeducation. Now Valentine 2010 did interviews about psychoeducation and whether or not it helps schizophrenic patients. Psychoeducation is where you learn about your illness, recognize triggers, learn about relapse and what relapse looks like. This reduces the blame, but it also helps patients to see what their disorder means and how knowing about the disorder can help them to try to get better. How is CBT used for schizophrenics? Therapists try to challenge the differences between psychosis and reality. They try to get patients to realize when they're hallucinating by filtering through and paying attention to reality. For example, by trying to get patients to say, it's just a voice, and by noticing it's not real. Therapists try to challenge delusions by asking for evidence against the delusions. Dickerson 2000 found that CBT alleviates symptoms and is 60% useful as they are unable to live normally due to the symptoms of schizophrenia. Maladaptive thinking, thinking that is not helpful or suitable, comes from schemas and general beliefs about the world, oneself, and the future. CBT focuses on learning how individuals who suffer from schizophrenia struggle with social isolation and lack of social support. They resolve this issue through working with a therapist or through group therapy. Strengths. Kingdom and Turkingdom 1991 found that 35 out of 65 in a 5-year follow-up were free of symptoms after CBT. 62 out of 65 were living in their communities. However, an issue with this research is that it was a small group of participants with no controls and there was nothing to compare it to, making it ungeneralizable and unreliable. Patient-therapist relationship is very important. They work collaboratively. They make the individual feel safe and supportive. The patient gets to make decisions for themselves and they are tailored towards their needs. It can lead to better long-term outcomes as shown by Kingston and Turkington research. Chadwick and Lowe 1994 found that when behavior modification was used, 10 out of 12 patients had a decrease in convictions of beliefs. 5 out of 12 rejected delusions. However, this was also a small sample size. Hoffman et al. 2012 used a meta-analysis and found CBT was best for anxiety disorder, anger control, stress, compared to other treatments. It was effective for both positive and negative symptoms. It's important to note that CBT treats both positive and negative symptoms, especially when comparing it to other treatments like drug therapy. Weaknesses. Unethical. CBT can be distressing. Patients need to question their hallucinations and delusions, as well as their own beliefs, questioning their sanity. Ethics. Informed consent. Patients can be having delusions, hallucinations, disorganized thoughts, and memory issues. They may not remember giving consent, or consent may be given by a guardian. Therapists can manipulate patients. Therapists and patients may get too close, and they may not like the therapist. They may have delusions about the therapist. CBT is needed to be used alongside other treatments so that the individual has motivations or the capacity to do CBT. Therefore, it cannot be seen as the overall treatment for schizophrenia.